Capsular bags can come in all different sizes, positions, but sometimes even different shapes, which can create problems during lens surgery. This 9-year-old girl presented with bilateral, upwardly sublux lenses. The first eye surgery was relatively routine, including use of iris hooks to support a capsulorhexis and a standard capsular tension ring to expand and recenter the capsular bag. An Ahmed-style capsular tension segment was then placed into the capsular bag and sulcus fixated using a Hoffman-style pocket, followed by placement of intraocular lens within the bag. A few weeks later, the second eye presents a different challenge. The bag is not only displaced but is oddly shaped with some crenellations on the temporal side with some kind of a colobomatous defect. Encouraged by results in her first eye and in previous cases, I try and proceed with the same plan. A soft shell technique with viscoat to tamponade the vitreous and heal on GV to create space in the anterior chamber is used, following by careful capsulorhexis. Capsulorhexis is obviously difficult because of the absence of zonular countertraction, but can usually be managed by care, as was the case in this patient. A small and slightly eccentric capsulorhexis is managed, and I start inserting the capsular tension ring. Things seem to be getting better. The capsular bag is being recentered and stretched. I'm hopeful that it will become an uneventful operation once the ring is in. However, as I feed the ring in, the capsular bag slides past it, and in an effort to rescue it, I use two 23-gauge coaxial forceps, one to hold the capsular tension ring and the other to hold the edge of the capsulorhexis in front of it, still believing that if I can manage to get the ring 360 degrees within the bag, then the bag will be stabilized. I seem to be winning initially, and as the ring is fed in more and more, I'm almost hopeful that the case should proceed like that other eye. But as we keep feeding the capsular tension ring and the capsular bag keeps stretching because of this, at one point it seems it's going to be impossible. At this point, I use both my forceps to grab the ring to try and stop it doing any mischief by bouncing into odd places, but further feeding in of the ring into the bag is entirely unsuccessful. It seems the bag is either too small or dish-shaped to tolerate a capsule tension ring. I therefore remove the capsule tension ring, thinking that I might have to sacrifice the bag. Having removed lens matter by IA with low bottle height, I'm surprised that when I put in Kenalog and remove it, there is no vitreous presenting. The dusting of Kenalog on the anterior vitreous face, temporarily where the capsular bag is deficient, clearly shows me that the anterior hyaloid has been undisturbed by all these maneuvers. I therefore proceed to implant a 3-piece intraocular lens into the capsular bag as far as possible. Obviously, normal implantation has to be adapted and the trailing haptic is positioned within the folds of the capsula. As the situation is unstable, I choose to suture the inferior haptic through the Hoffman-style pocket which I had created in anticipation of an Ahmed segment being sutured in to the ciliary sulcus. The lens now looks stable, however there's an anterior capsule covering 1/3 of it as it has wrapped around the edge. I want to clear the visual axis, so cut it with coaxial 23-gauge forceps and then try and peel it off in a maneuver similar to enlarging a capsulorhexis. Obviously, the child's eye has an elastic anterior capsule and this is not easy. I do not want to risk it tearing around the IOL, and I therefore stop at this point and approach the tear from the other side. Having freed the capsular bit from both sides, I choose to cut it and remove it, thereby making the visual axis free of any capsule. Myocol, cefuroxime, and the eye is looking good. Thank you.